right, let's get started. Welcome to today's panel, Aligning Mission and Margin in Healthcare, conversation with Halle Tecco. I'm excited to have this chance to chat, but I just want to have a couple introductory remarks. I want to introduce you all to HBHI and our webinar series. So I'm Dan Polsky, Director of the Hopkins Business of Health Initiative. HBHI, as we like to call ourselves, we're a Hopkins-wide initiative bringing together scholars from across the university who are working together for an accessible and trustworthy healthcare system for the nation, one that delivers value and affordability to society through a focus on the role of business and incentives. So as part of this effort, we host a monthly conversation on the business of health, where we bring experts together to discuss emerging issues. And today, we're fortunate to have Halle Tecco with us. She's dedicated her career to making healthcare massively better. She's the founder of Rock Health and has backed and advised dozens of healthcare companies. She teaches future healthcare leaders at Columbia Business School and Harvard Medical School, serves on the boards of Collective Health and Co-Fertility. Tecco's work has been featured in the New York Times, Wall Street Journal, and Bloomberg. She was named one of Goldman Sachs' most intriguing entrepreneurs, listed on Fast Company's most creative people in business in 2023. She's been out on a number of speaking tours as she promotes her book, A Massively Better Healthcare, which is same color as my background, so that's only gonna, there we go.
And your suit.
And my suit. It's, yeah, I wore the colors of the book.
I love it.
Just in honor
Thanks
of
for
the
the
book.
support.
But the most important part of her biography here is she has a master's in public health from Johns Hopkins University. She also has an MBA from Harvard Business School, but you know, that's all right.
You'll forgive me.
Yeah. So I'm thrilled to have a chance to have a chat with you. Maybe just to, as a kind of just say a couple words about your book and how you've been out.
Yeah.
You know, just talking with people the last few months.
Yeah.
Just as a way, you know, before we kind of go back to your some of the things that have kind of driven you to write this book. But just I'm just curious about your experiences and kind of sharing your wisdom over the past few months.
Happy to, and thank you so much for having me. To everybody that's joining us on this Friday afternoon, really excited for the conversation that we're going to have. So one question I get a lot around my book is, how long did it take you to write it? And I always answer very cheekily, my entire career. And really, I always knew I had stories to tell, and I would kind of put them aside in a Notion document that I had been keeping, and you know, had hoped that someday I'd feel ready enough, have the courage, or felt like time in my life where I felt really ready to write the book. And just quick story before before I say more, which is when I first wrote the book, I got an agent. I got a book agent, which is kind of the first step in writing a book. And the agent was about to go on mat leave. She signed, and she said, you know, finish up. And then when I'm back from mat leave, we'll start pitching publishers. I had written, I don't know, probably half of the book at that point, and had beta readers that were kind of going through and giving me feedback on the stories and the frameworks. A lot of the frameworks I developed over years and years teaching a course on digital health at Columbia Business School. But when she got back from mat leave, I had the book, the entire manuscript written, and I shared it with her, and she read it, and she said, this is great, but I actually think the audience is too small. So I'm not going to be able to pitch this to publishers. And I was like having flashbacks to when I started in digital health at Rock Health, when we were starting Rock Health, and people would say, the market is too small. No consumer is going to want to pay for healthcare. This is like, you know, too early, yada, yada, yada. We got a lot of no's. I got a lot of gaslighting based on people's feelings on how big something was. And I've always looked at it, I'm like, this is nearly 20% of GDP. There's nothing small about healthcare. And when it comes to the book and like the market size for the book, I'm like 11% of Americans work in healthcare. How could this be small? And but the book was written, so I was gonna get it published. So I ended up just going across the street at Columbia and talking to the Columbia University Press. And I said, "Hey, I wrote this book, and their mandate is to publish stuff from their faculty members." And they immediately said yes. And so I was able to kind of move forward. But I think that's been a common thread in my career. And I know there are a lot of students on this call, but something that you might hear when you are perhaps ahead on a trend or early on something that you're excited about, there will be people who are just non-believers who just don't think that there's substance in something that you see because you can see around the corner. And it's something I've always I've faced multiple times in my career, including in this book. So when my book came out, it was instantly a bestseller, #1 book on Amazon in the entrepreneurship category. We sold out, completely sold out twice. And I really hope that that publisher or that agent that dropped me saw. I don't know if she saw, but I hope that she did see because I was very happy with the outcomes, and I knew that there were readers waiting for a book just like this. I talk to them every day when I talk to founders. So, alas, here I am and excited to be an open book and talk about my book and promote my book. And hopefully, everybody on here has read it or has at least ordered it on Amazon so that you can read it soon. I do think it is a really helpful read for people who are on their journey in innovating in healthcare.
Well, that's for I know most people on are passionate about the health and healthcare space, and so it's inspiring to hear that you stick to what you believe and you find a broad audience.
Yeah.
And I think that that holds true for. So now, just to segue a little bit to
Yeah.
give us some background in your journey, and especially with the students that that I teach, I know that are really mission oriented and see digital health technologies, and now AI, it seems to be every other word that comes out in our space about
Yes.
opportunities to do things differently in healthcare because the needs of addressing health challenges throughout our system are still very, very large. And so the opportunity to do something different and something innovative and bring, the knowledge that, so many of our experts in our environment have that can, kind of drive new ideas. It just seems like
Yeah.
kind of a low fixed cost way to get into it. And I know that that isn't so easy. There are kind of fixed costs that are often in just kind of knowledge and understanding the system.
Yeah.
So, you've had a lot of experiences over the past decade as this kind of digital health explosion has been a part of our past decade. So what are the assumptions that entrepreneurs and investors, so if you're looking to get into
Yeah.
this space, what might what might you be thinking that maybe is a little bit off? And you can realign folks who are thinking about jumping into this. Well, let's just start there.
Yeah. And it's been a decade and a half for me since I founded Rock Health in 2010, 2011. So um, it's just been so incredible to see this space flourish. And I talk about this in the book, but really when I was starting out, there wasn't a community. Even like the healthcare club at my business school was very much folks who wanted to work at hospitals or health plans or pharma. And so we really had to work hard to find kind of our crew of people who believed that technology could make a positive impact in healthcare. And there were more non-believers than believers. And so it has just been so incredible to see how large the community has gotten, how many great companies have been built, how many lessons have been learned from those who did not work out. But I've seen a lot of assumptions that entrepreneurs tend to make that don't work out. And one of them is that they fall in love with a shiny technology and then they hunt for a problem to solve within healthcare. And this leads to a hammer looking for a nail dynamic. And in the book, I have a whole chapter about working from the inside out and how important it is that you start from the problem you are trying to solve. You become an anthropologist, I use that term, of the problem that you're trying to solve. And then once you feel like you really understand the unmet needs of the population you're trying to serve, then you look at the potential solutions. And the reason you don't start with the solutions is because in our world of tech and AI, those can, will, and should change over time. And so you really have to be flexible about what those tools are. And a great example of this is the recent introduction of GLP-1s. There were a number of weight loss companies already out there that had a variety of different programs like Noom or Weight Watchers or Verta Health that all took different what they considered proprietary approaches to supporting people on their weight loss journeys. When the GLP-1s came out, they all looked around like, do I go against them and say this is an alternative to GLP-1s? And some of them did. Some of them tried to point out the challenges with GLP-1s, whether that was price, which has been obviously has come down, or side effects, access, whatever it was, and tried to really just double down on what their existing solution was. And then others looked at the opportunity and said, look, this is just another tool in the toolbox. And if my goal is to help people get to a healthy weight, then I need to take into account all of the potential solutions that are out there, including GLP-1s. And those are the companies that have actually, like Noom, Omada, that have actually figured out what their unique position is in terms of, offering wraparound services with the GLP-1s to make their offering truly unique. So that would be the first thing, is like, just be the expert in the problem you're trying to solve, and don't just fall in love with the new shiny technology, because that's always going to change. It's the solution you need to be really passionate about. Another assumption that I saw, especially in my 9 years living in Silicon Valley, was that the move fast and break things famous mantra that was up in the early Facebook office, that we kind of bring that sort of ethos to healthcare, and that healthcare is really slow, and that we just need to we need to move faster. We need to have a sense of urgency. And while I agree that we need to figure out how to better innovate within healthcare and kind of tighten up those feedback loops, you really cannot do that without sacrificing clinical integrity. And you really don't want to sacrifice clinical integrity for speed. In fact, you have to kind of do the opposite. And I say this all the time, but I say it in my book, is you have to go slow at first in order to go fast. And if I've learned anything about healthcare, that we really are, in a lot of ways, a special snowflake. I know we wish we were not, but there are unique workflows, infrastructure considerations, and most importantly, regulations that we have to work within. And so spending those early days really figuring that out and doing it right, so that you can scale, so that you can hit the gas once you kind of have figured all of that out, I think is really important. And then the last assumption that I'll share is that a lot of people come to healthcare thinking that a better product will win. And unfortunately, in healthcare, the best product does not always win. In fact, it usually has nothing to do with the product at all. And if you've ever used provider software, then you know this. Distribution and sales win. And in a lot of ways, a lot of things are winner takes most markets. It is in most markets within healthcare, it is winner takes most when it comes to software. Epic is a great example of that. And a great product just isn't usually enough, at least when it comes to B2B. I do think now that we're seeing a growth in direct to consumer, someone deciding between an Oura ring or a Fitbit watch, I do think that product there is more important. But when it comes to B2B, I think people who kind of come in and assume that they're going to build something better, it'll work. And an example I'll give that just recently was, I was talking to a hospital CMIO, and he was saying that they had been, for the last year or so, been using this new AI scribe from a very well-funded AI scribe company. There are many of them now. And he loved the product, and he thought it was a great tool, and his clinicians loved it. But Epic came to him and said, hey, we're launching this as a feature of Epic. And guess what? We're going to charge a tenth of what that startup was charging you. And he told me he had no choice. That sort of that price differentiation was big enough. He said if it was, the same price, I might have stuck with the better product. But in this case, the hospitals, he needed to do what he had to do for efficiency and cost, and he unfortunately dropped the fancy startup Scribe and went with Epics, which was not as good of a product. So I would say those three things: the assumption of falling in love with the shiny new technology and thinking you can just bring it somewhere in healthcare, moving fast and breaking things, and then the idea that the best product wins.
That's great. I think it demonstrate, as an economist, we think about how, like in free markets, hopefully if you have a good idea, quality should win out. But, if we have these, monopolists or close to monopolists that are hard to move, once you've invested in Epic, it's billions to move out of it,
I
and
know.
they have such a such control over what comes out, particularly in the digital space. So I think the other thing that I think has a lot of control is just the third party payer. We have insurance. You want to get your thing covered through insurance. If you're gonna, I don't know if that's what you mean by B2B, but I guess if you're working with providers, they're going to want to have it reimbursed, and there's a regulatory structure around that. And I think for technology, that there's a desire to move directly to consumers, because maybe you don't have to go through that whole maze. But I guess, so I set that up as a kind of a background, and so many of our students in our atmosphere here at Hopkins, around public health, and business, think about how to drive preventive care and how to really push people to stay healthy. And that seems to be a real opportunity on the one hand for direct to consumer, but the scale issue that you mentioned too, and the barriers, often the scale comes through insurance. And prevention is not necessarily, it could have a good idea from a societal perspective. This is really going to keep people healthy, keep them out of the healthcare system. Insurers should be interested in not spending money, but if our private insurers, how much investment can they make when they're preventing diseases that happen after you turn 65? But I guess, so, that's how I think about, all these, kind of more conceptual basis, but you must see this playing out, on the ground, when you're supporting companies. And maybe you could just talk us through that and say, what are the avenues if you're really pushing preventive care?
I mean, you could teach an entire class on this, right? There's so many places where we know exactly what to do, but no one is willing to pay for it. And it can be so maddening, because we're really stuck within the system and we have our hands tied because of, as you said, annual enrollment. And there really is not a lot of prevention where ROI pays back in under 12 months, or, a few cases, but broadly, that's not enough time. And it's one of the biggest problems we face. I asked the founder of Oscar Health, who was a classmate of mine, why don't you offer at least a 5-year plan? And he said that legally they're not allowed. They're not even allowed to give a discount on your second year to keep you as a patient, which is very interesting, because you could also imagine a health plan that was pricing was set up where you pay, maybe it's a 5-year agreement and your premium goes down or something. So that is a challenge. Employers are slightly more in line because an average employee stays 2 to 4 years now. You get a little bit more time, but also better health often means better productivity. So I do think that they have stronger incentives to pay for these tools, and employers have been a big market for digital health, although that is getting tricky because now employers are tired of the point solutions and really now focused on cost reduction above all else. In fact, there was a chart where it showed how we just kind of crossed between the number one priority used to be employee retention and having great benefits, and now benefits leaders are really just looking to lower costs because it's just gotten so high for them that's their number one. And in the employer space, like Omada Health, I think it's a great example. They're using a kind of a performance-based pricing, so they only get paid when members are achieving clinically meaningful results like weight loss or A1C reduction, their diabetes prevention plan. And so in that case, you're taking that payment risk away from the employer, away from the payer, and taking on that risk yourself. And I think that's a super clever business model. And we're seeing more and more move to that value-based care arena. Do you know of Cityblock? Yeah.
Yeah.
Yeah, so they take a value-based, very hyper local approach for dual eligible, so people on both Medicare and Medicaid. And what they do is they integrate primary care, behavioral health, and then something that we love at Bloomberg School of Public Health, which is the social determinants of health. So they have community health workers that are supporting their members with transporting them to appointments, making sure that their pantry is stocked with food, housing, anything that really can relate to big barriers to achieving health. But because they're focused on medically complex and high acuity patients, their high touch approach has actually had very positive results within shorter timeframes. And some of the things that they measure is like emergency room visits, and they've been able to reduce them by 15% because they're working with a specific population that does have very high costs. Then when it comes to the broader population, we end up having to pay on our own for any sort of preventive health measures that are kind of outside of what is required by our health plans.
So the high touch can be for those that would have high baseline healthcare costs that could potentially be reduced.
Exactly. I could not be a Cityblock. That would increase my costs if I were to go on Cityblock. So what they're doing is they're the most expensive patients and helping them save money there. But yeah.
So that the flip side of that coin is preventive health measures for the healthy, which is probably not a place where there's an ROI in the short term for insurers, and that's kind of been the growth of this direct consumer market, which is really you have to have not only a willingness to pay but an ability to pay for that, and then it can drive it kind of drives some of the health inequities as we move more of this kind of primary preventive care outside of our kind of subsidized insurer markets.
Yeah. And I think there's a huge opportunity. I have this matrix of sick to healthy and engaged to unengaged, and really the unengaged and healthy group, like that is such a huge opportunity to make sure that they stay at least if they're not sick yet, like let's keep them healthy. But if they're unengaged, if they've never been to a doctor, if they're uninsured or have low medical literacy, like this is a population that has for multiple reasons been disenfranchised by our healthcare system. And that is, to me, such a big opportunity for public health, for digital health to help intervene and prevent, again, down the road, major issues. And this is why I love public health, is because we know that there's a tangible ROI on the public health interventions that we do. And it's like $14 ROI for every dollar invested in public health. The problem is, who's willing to pay that? Yeah. We kind of have right now, we're gutting public health versus investing more into it. So it's definitely an issue because we're somehow willing to pay for emergency care down the line versus paying to keep people healthy to begin with.
So there's the primary prevention, but just to move a little bit to kind of secondary prevention and primary care, because I think that's almost in the middle of these two extremes, that healthy primary prevention, many are unengaged, tons of opportunity there. The engagement problem's huge. And then on the other end, there are kind of care management programs, focused on where like healthcare costs could be saved. But in the middle, it's people are on chronic disease medication or need chronic disease medication, need management, regular connection with a regular provider. And this is this kind of middle piece. And earlier you brought up value-based care. There's
Yeah.
uh, so much put on this middle piece. Let's call it, the primary care
Primary care. Yeah.
system, where there's huge opportunity and potential engagement, or people that are engaged but just aren't getting that kind of secondary
No,
prevention that they need, and then they too end up in the ED. So
totally.
is this an opportunity, or what the examples
Yeah.
of where digital health or moving into AI, like, can you give us some optimism here in
Yeah.
this space?
I love primary care the way I love public health because it is one of the highest leverage areas for improving both outcomes and costs. And I've never met a primary care physician or a pediatrician that I didn't just absolutely love. Like they are the best. But they face a massive, what I call math problem because we have provider shortages and burnouts. It's underfunded. The last data point I heard was 1 in 3 Americans don't have a regular primary care physician. We have primary care deserts. So, major issues in terms of making primary care available to all. Um, there's uh, there's a company that I profile in my book called Aledade, and they work with independent primary care physicians, which unfortunately is like a dying breed since the corporatization of all of healthcare. But they specifically focus on independent primary care physicians who want to move to a value-based care model. So they've seen that fee for service is adverse to how they want to treat their patients, and they want to move to value-based care. And so they basically provide that operating system for these small, lot of rural independent primary care physicians to better manage their patients from kind of a population health level. As you know, primary care physicians have patient panels in the thousands. And so it's very different from the relationship someone has with maybe a concierge doctor or a direct primary care doctor. They're managing large patient panels. And so the case study I share is one of their rural doctors in Louisiana. And the story that that doctor told me was about how they were able to identify patients within their population who had hypertension. And they basically helped them do very simple things like call the patient back in. Well, first identify the highest risk patients, call them back in, help adjust their medications, and do more follow-up. And so basically improve their patient engagement. And they were able to get their control rates up from 63% to over 90%. So I think that's a great approach because Aledade is basically, and it is started by a primary care physician, basically saying, okay, we already have these physicians who are in the field. How can we help them do their best work? And when I think about digital health and the biggest opportunity, it's really to enhance the care that people want to deliver. Clinicians want to be able to give the best care possible and in so many ways have their hands tied. And so where digital health can come in and make their job more impactful, like that is the place to go.
I love these stories because it talks about digital health as an enabler of care, like hands-on
Yeah.
care, where like you said at the beginning, working from the inside.
Yeah.
So uh, so much of what I hear going forward about like the opportunities for
I
disruption with
know what you're going to
artificial
say.
intelligence,
Yeah.
and there might be different ways to deliver care that might really bend the cost curve. Like, if we just had,
Yeah.
labor costs a big part of delivering healthcare. And so that's where the bending the cost curve comes. We can, go visit our bot instead of our doc. Might be,
Totally.
overstating. I'm not really sure yet.
Yeah.
Um, but and I'll add too that I just came from our National Societies Conference, like Association for Health Economists, and I was on a panel like, will AI bend the cost curve, or is it going to lead to increasing costs? So, like,
Ooh.
if you were
Was it
on
a
the panel,
debate?
we all said pretty much the same thing, which is like, we have no effing idea. Um,
Yeah. But
uh,
I love this moment because just like the intellectual exercise that we're doing on a daily basis, having these conversations and thinking about how this is all going to unfold is so interesting. We don't know.
Well,
None of us know, but we
that's why
can
we said
all,
like we'll have the same panel next year, hopefully
yeah.
with data. Yeah.
Yeah, we should have a little more data. But yeah, I mean, it's so interesting to think about where things are going. But anyways, I'll let you ask your
Yeah.
question.
So, how do you see, if you were sitting on the panel, what would you
Yeah.
say are, where where do you see, opportunities or potential, barriers to kind of both the implementation of AI in this, in healthcare, but I think
Yeah.
from a macro perspective, how might it, where might it land in terms of some of our biggest challenges? And in this one case, it's like rising healthcare spending.
I know, yeah. I mean, ideally that the value will accrue to patients and ultimately society by lowering costs. But as you said, like we don't have a lot of data that is yet pointing in the direction we want. And because of that, the value today is unclear. And actually, some early AI deployments have actually increased spend rather than reducing it. But it's because it's all been focused on revenue cycle management. That was like the low-hanging fruit for hospitals to health systems to adopt. Um, and that is coming from these AI scribes, which I will note that all of my clinicians friends unanimously have positive things to say about the AI scribes because of how much time it is saving them. So in terms of like uh, clinician experience, what I'm hearing, and I'm sure there are studies on this, is that it is improving the job because, as we all know, the EHR created a lot of friction and a lot of pajama time charting for billing for these clinicians that really changed the job because clinicians used to just go home and then be home and their work was behind them. And now they, would go home and have to chart. And so this AI scribe was positive that way, but we also saw that billing went up because of it. And so, that is a little concerning, but I think overall the goal is for AI to bend the cost for curve and to be deflationary. And to do that, it must move beyond documentation, beyond coding. We have to kind of get through these like AI bot wars between providers and payers. And it needs to lean towards like true labor substitution. And that is hard for us to talk about because, as I mentioned when we first started talking, 11% of Americans work in healthcare. But healthcare's largest opportunity is to reduce the $2.9 trillion in labor spend and automating portions of that $1 trillion administrative burden that has come because of technology. A lot of that administrative burden we've created that over the years. We didn't used to have so many administrators. And that is hard for us to stomach because what happens to those jobs? What happens to those people? There are a lot of areas, including Baltimore, Nashville, Pittsburgh, where healthcare is the thriving economy for entire communities. So we really need to think through the trade-offs there because this is not sustainable. We cannot continue to spend more and more on healthcare labor. It's going to bankrupt the country, and it's already crowding out other things that we need to be spending on. But in order to do so, we're going to have honest conversations about what that means for fewer jobs. So, I mean, you also asked about kind of what would it take for all of this to kind of play out. I think some of it's just time, and things are moving and changing so fast, but healthcare still moves at healthcare speed. I think we've sped that up, but we still we take caution in adopting new tools, and I think that's appropriate. But also regulation is going to have to change. You mentioned, talking to bots, and I personally would love to have a digital twin of my asthma doctor and be able to ask her questions in between the 15-minute annual visit I have with her, and think of the value that there is of, I'm going to go and do that in ChatGPT anyways. I would imagine that clinicians would rather have a cloned version of their brain and their knowledge that knows when to escalate, but also knows when to answer common questions in the way that my clinician would answer it for me within the context of my healthcare background. But we have to catch up in terms of regulation, and we have to be able to answer the question. I'm sick of hearing this question because it's like, we'll figure it out. But the liability question, especially
Liability.
around clinical decision making and who's liable, well, like that is surmountable. That to me is like the least of our problems. Like we can figure that one out. But I will say the only last thing I'll say on this is that even if we're able to lower the cost of healthcare and premiums for the average American, we may see Jevons paradox and demand may rise because I do think that there's a lot of unmet demand in the market. I don't know how much. I don't know if you have looked at the data, but if we were able to lower the cost of care, would that be made up with increased demand? So any kind of lasting bending of the cost curve would need to mean that productivity gains would have to outpace any sort of increased utilization.
That's a great point. I'd say that just on the increased demand, it'd depend if it was within insurance or outside of insurance, because we already have a demand induced through insurance. So I'm so into this conversation. I forgot to really plug the Q&A. I'm totally monopolizing your time.
I see some Q&As that we have 6 questions.
We have some coming in, so I think I'm gonna kind of blend that in, and then we'll leave 10 minutes at the end focused on questions. But I'm going to start with this one that just came in, since it's exactly on the issue we're talking about, from Carissa Cooney here at Hopkins. So AI is, you can see the question, but I'll read it out loud.
I can see it, but yeah, let's read it.
AI is contributing to higher costs pertaining to the preauthorization process, or WAR, between third-party payers and clinicians, leading to hiring more administrators, nurses, and higher cost AI programs. So the vendors are winning in this war, maybe on clinical practices to address denials. Any thoughts on moving forward?
Yeah. I mean, that's what I was saying is right now we are seeing that the increase because now we have all these revenue cycle management tools and coding tools, that we are seeing an increase in healthcare costs due to that, which is interesting, and having these wars, because actually it's very interesting. I would never have predicted that providers would adopt these AI tools faster than payers, but they have. Like, we've seen incredible adoption. And to me, my theory is that COVID forced providers to adopt telehealth. They were uncomfortable with it, but they did it, and they had to do it quickly, and they had to get everyone on board. And then all of a sudden they were like, oh, actually, we're more tech savvy than we thought we were. We can do hard things. And departments were built, and processes were built. And most importantly, culture was changed so that these health systems approached technology more confidently. And so that is my belief on why they have been so fast in our industry, fastest stakeholder to adopt AI. Health plans, though, are now looking at this like, oh shit, we need to catch up. And so we are seeing big adoption and investments there as well. The one piece that I do think I'm waiting for, because I think this is going to happen, is now you have the patient who's constantly in between the provider and the payer. And now that it's pretty easy to upload your bill to AI and look for errors and help you write any sort of letters to the health plan or to the provider, either way, to kind of fight for lower costs. I think we are going to also see, maybe there'll be specialized tools for that. But I saw one, Defensive Health is doing something like this. But I think that everybody's kind of like now has better tools to fight. So my hope is that we get to a more truthful place where price is more fair, and we all kind of benefit from that.
Love that point. I hadn't thought about it that way. That is really okay. I have a study I need to do. So I'm going to ask one more of my question here, and then we'll focus on some of the Q&A. So keep them coming. So much of your impact over the years and has been in the area of women's health and health equity, and you're advocating for investment in this important area. So for so many in our people listening, might be thinking about, this is a place I really want to make a difference too. Can you speak to that, where some opportunities are, or why there's underinvestment in this area, and just give us some motivation for really attacking these important issues?
Honestly, I think the greatest opportunity now is to see women's health as simply healthcare. And we need to close the data gaps where women have been excluded from clinical research for decades, and also even within digital health, kind of treated as not without unique consideration. And every healthcare company that has women customers needs to become a women's health company by understanding how they're serving the unique needs of women and how they may differ from men. And we don't want to repeat the same sort of mistakes that we made in pharma, for instance, in digital health. Um, in terms of other than that, opportunities specifically, I always say like the opportunity is going to be different depending on who you are as a founder. I find that you have to just be so obsessed with solving the problem. It is so hard to be a founder, even harder to be a founder in healthcare, that if you are not genuinely driven from some sort of like inner place to solve this problem, it's going to be that much harder. So for me, I've spent a lot of time, I dealt with infertility. I went through IVF a lot to have my son. And that really pushed me to start now two fertility companies. And I'm just like super knowledgeable from a patient perspective about that experience, and I care very deeply about that experience. You might face, or someone that you love might have faced something within their healthcare experience. It can be, a specific condition. It can be, medical errors, billing, whatever it is. To me, that is the best place to start. So whenever someone asks me, like, what are the white space opportunities? I say, it depends on who you are. Going back to women's health, I will say the capital issue has been something that has been very frustrating my entire career, and women's health has been very underinvested for two very simple reasons. One is that women-led companies across all sectors already receive under 2% of venture funding, and this number has not budged in my career, sadly. In fact, lately it's gotten even worse, which is shocking, but it has gotten worse. And so women tend to be the leaders of women's health companies. And so that becomes, a challenge as a woman founder in any sector. And then two, investors tend to invest in things that get them excited, that they understand. And I really don't blame them for it. I don't like to invest outside my areas of expertise because I can't build conviction if I don't understand it. So if an investor, and most investors are men, if they can't relate to a pitch on birth control or menopause, they're likely to not invest. So we have a problem of, not enough money going to women founders, but we also have a problem that there aren't enough women investors, or at least investors that understand the unique needs of women.
That was a motivational answer. I really, really appreciate that, and can relate from my own experience very much. I want to call out a question from Ritu
Okay.
Agarwal. Ritu is our co-director of a center that sits in the Carey Business School, the Center for Digital Health and Artificial Intelligence. Ritu is extremely busy faculty member here at the Carey Business School, and a true expert. And so her question is, I would love to hear your thoughts on one of the biggest frictions in healthcare that poses a tremendous obstacle to digital health and AI, data interoperability.
Mhm.
What's your prediction on when we'll get to a place with this?
Gosh. Um, I don't know when we'll get to a better place. I would say this kind of also goes back to what we were talking about with incumbents and anti-competitive behavior, and the way that data has traditionally been treated by companies is that it's their data, not data of the patients. And so I think it's been used as a business tool and a competitive tool versus being used as kind of the for the greater good. And so in my book, I have a whole chapter on being a good steward of health data. And it goes two ways. I think we have to protect healthcare data. Obviously, this is very sensitive data. It is a high target for hackers. We also happened to change healthcare situation, which happened while I was writing the book. And because healthcare data is so valuable on the black market, startups are vulnerable to hacks. And so I think making sure that founders are taking that really seriously, because losing that trust by having what happened to 23andMe, for instance, when their data got stolen, is casts a dark shadow on everyone in the space. So we really need to take that seriously. The other piece is like we need to use data for the greater good, and there's not enough data sharing and interoperability so that we can use data to make medicine move faster. And maybe it's not your company that's doing that, but if you are able to build partnerships and open data in a way that it benefits all of medicine and healthcare, I think we need to make better efforts to do so, because right now there's just a lot of data hoarding, and I think that needs to change.
Yeah, a lot of money to be made off of your own data, making it hard to release
Yeah.
it. Yeah, for sure. It seems like a place for where policy is going to have to move to make a
Yeah.
difference here. We have our other co-director has a question from the Center for Digital Health and Artificial Intelligence, which are
Ooh,
supporting this
cool.
event too. So Gordon Gao, first to call out to the part of your book, Too Long Didn't Read, gives a chance for people to just whiz through the highlights of the book. So his question is about Dexcom and Omada, examples in your book. Now that CGM sensors are available over the counter and increasingly used by people without diabetes, we're seeing growing volume of user-generated health
Hmm.
data. How do you think these data can be effectively integrated into the healthcare system,
Hmm.
incorporated into clinical workflows?
Hmm.
I guess Gordon sees a real opportunity
Yeah.
for these data
What
to.
a what a
Yeah.
good question. It's like the $1 million question, right? Because I've had I've used all the trackers, and I've, printed out my data, brought it to my doctor, and they're like, okay, thanks, I'll put this over here. We don't have enough time with our primary care physicians for them to take a look at your data. And that's just, a fact of the system. I think that actually is where AI can be useful. If that data was available for my primary care physician, and AI could quickly look through it and flag things that could potentially be useful, or clues, or things that would indicate that I need to be tested for this or that, then I think that data would be less burdensome and more valuable. So I think that this is kind of a good moment for us to kind of solve that problem of the disconnect between the data that we're creating in our everyday lives and the way that we're able to interact with our healthcare system. The other thing that we're starting to see is that I think I just saw this headline yesterday, so I could be wrong. But I saw that like Whoop, the tracker, is like they're like building out a clinical use case that you can actually, work with clinicians within it. I know Aura has like a partnership with LabCorp to do testing. I mean, all of these tools are trying, to me, this is a response to the healthcare system not knowing what to do with all that data, because most doctors within our current system have no idea how to handle, let's say, Aura data. Aura is like, well, maybe we just work backwards, and we'll do that testing because we can kind of suggest and look at what someone might need. So I'm not sure what's going to happen there, but I do think that AI is going to unlock the usefulness by making it less noisy and being able to surface the data points that might be the most valuable.
Yeah, thank you. That was really, really insightful. It's like it's unclear whether it's the our incumbents are going to be able
Yeah,
to adapt, or whether it's going to have to come
totally.
from the
Totally.
disruptors.
And I have a quick
Um,
Dexcom story. So Dexcom is profiled in my book, and they sent me two sensors to try. And I tried one at first, and it was like my blood sugar level was very normal. It wasn't interesting. There was nothing actionable. Last 2 weeks, I basically followed a line. I looked maybe once every other day because it just wasn't interesting to me as someone without blood sugar issues. Um, and then I had another one left, and I had had COVID, and I was having some like post-COVID complications a few months later, including feeling really faint and very fatigued, and shaky. And I went to my doctor and they and my primary care physician, and they had me see a PA, and she concluded that it was just anxiety, and she prescribed some Xanax and was like, "You have a lot on your plate. It's just anxiety. Like, take one of these so you can sleep." Um, I was like, nah, like I've had anxiety. I have anxiety. Like I know what's anxiety. Like this is different. And I remembered that I had that Dexcom, and I was like, let me see if I have any blood sugar levels. And my blood sugar was under 60. My blood sugar was very low. And I was able to I went to my kitchen, I got some cookies, I got some orange juice, and I watched the number get normal again and then get a little high. And I took a screenshot and I sent it in my chart and I said, look, it's not anxiety. My blood sugar is really low. And then I looked up some studies and there was some maybe potential, thing that had to do with COVID. I don't know. But that's to say, I think that I'm a huge fan of these tools because I believe that my needs and most of our needs have not been met by the current healthcare system. And as these sensors become more available and lower costs, like so be it. Let people find the answers that they need. It's been, valuable to me. So.
That's a great, thank you for sharing that story.
And
So I'm going to
I got
move
to meet
to,
the CEO and I told him that story and he was like, wow, cool. And the funny thing is when your blood sugar, because it's a consumer tool, if the blood sugar is below a certain amount, it just says it's low. It doesn't give you that actual number. You have to like download the data to get that number because it's not technically a medical device. So I gave him
and
that
it's
feedback,
within the
but
regs. That's interesting.
yeah, yeah,
So Jonathan Fate, who I think you know, has a question
I do.
here, um, and who's also a DRPH candidate here at Hopkins.
Oh, I didn't know that.
Yeah, how about that? What if it turns out that tasks like interoperability are actually far better solved today than it seems, but the narrative we're hearing about publicity is more about the negative than the positive, therefore drowning out the success stories. And I think there's a
Oh,
little follow-up too, a little further down, but I'll let you um, tackle that one.
yeah. I mean, it sounds more like a comment than a
Comment?
question,
Yeah,
but
okay.
yeah, perhaps. I mean, I certainly think squeaky wheel is louder than the other. So um I wouldn't say that it might be better than it seems. Um, but I would say, even my chart has only been around for, what, 2 years. We've traditionally not been able to get our health data. And I've had cases where I've tried to get like MRI results, and it's like, okay, I'll mail you the CD, but you have to pay $100. And it feels like we're kind of far off from saying that our data is our own and it's being used to the best of its ability while being fiercely protected. Because I don't think we're there yet, but it could potentially be better than I'm making it out to seem.
Uh, Thank you. So the next question I'll read here from Bijal Patel, who's a Carey alum, a clinician leader, um, and a supporter of our student body here. So I'm happy to read his question here. I'm happy to read all the questions. Just I'm kind of going from the
Yeah.
bottom up here. So looking 5 to 10 years ahead, what is one healthcare workflow or business model that AI will fundamentally eliminate or redesign? What should health systems and physician groups engaged in value-based care be doing today to prepare
Ooh.
for the future?
Okay, those are two big questions. I'm going to say that AI is going, this is just a prediction, who knows if I'll be right, but I do feel like AI is going to become the front door for acute care. So instead of going down to the minute clinic when you're starting to feel sick, you will first use AI and it'll help you triage where you need to go and what you need to do. And I will say, right now, people will go to ChatGPT. What would be better than that is if health systems and physician groups had their own version. And I hear a lot of providers complain about patients using AI, and I've talked about this on my blog. I have a Substack. Look up my Substack. I talk about a lot of the stuff that we've been talking about. But I heard a clinician specifically complain about the AI tax and was saying that patients using AI to find information before their visit waste my time. I'm spending more time with them and undoing the misinformation from AI. And I just thought that was the opposite approach of what we need to be saying. We need to be saying patients will use AI because they have unmet needs that we have not fulfilled. My job is to then say, how can we ensure that where they're going is safe and accurate? And so in that case, I think that hospital is in a very good position to say, we are your front door. You have a health question, your ear hurts, you're getting a little stuffy, like come here first. Because if there is a low friction, free way to better triage and free up urgent cares and emergency rooms for real emergencies, that is a great way for us to improve efficiency and lower costs within our healthcare system.
Yeah, that's great. It fits in the incumbent and a disruptor model. The incumbents are comfortable enough to say, it's not fitting into my model, but maybe we need to really think what our customers, how they see the world.
People are going to be using these tools. I even have like a whole chat within all of my AI agents where I'm asking healthcare questions, and I know how to use it and I know how to take things with a grain of salt sometimes. And it's not perfect, but it's the worst version that it'll ever be. And I think we should just be focusing on making it better. And I know we're running low on time, but I will shout out what OpenAI is doing if you don't know. So my Rock Health co-founder is now head of healthcare there. And they built something called Health Bench with input of over 250 physicians around the world. So they've built this like model performance tool, which is judged against the clinical standards versus like generic AI benchmarks. And they built out a safety-focused rubric to continually improve the model. And they know when it's a healthcare question that they need to answer it differently. This is all publicly available. So any researchers or healthcare organizations or interested parties can like independently assess the model and its strengths and weaknesses. And I think that them building that out in the open is great and it's really important. And I think we should be, especially clinicians, I'm not a clinician. I can speak on behalf of patients, but only clinicians can speak on behalf of clinicians. And they should speak out and demand that it continues to get better because people are going to use it. We're not going to stop people from using it.
I'm going to go for one more question here from my colleague, Anthony Lung, who founded a group, the Innovation Translation Council in our School of Public Health. And you can see in his question the aims of his initiative.
Okay.
He says, what would be one piece of advice you advise someone who wants to develop an AI-based healthcare or public health tool that can be deployed at scale? Any thoughts on some business model that can also develop this kind of mission-oriented tools in a financially sustainable manner? So a very broad question here.
Yeah, honestly, I have a good book for you. It's called Massively Better Healthcare. And it truly, like I really do walk through all of that. So please read it.
I think that is just a wonderful place for us to stop. Forgive me for not getting to all the amazing questions in the chat. It really speaks to our phenomenal community here, the Hopkins Business Health Initiative, and all the experts that come monthly for our talks, and also just the excitement our community has around welcoming you, Halle, to have a chance to speak with you about all the issues you care about, which we care about as well. Thank you very much on behalf of our entire community for being with us.
Yeah, thank you so much. Have a great weekend, everyone.
Bye-bye. Bye, everybody.
Bye.